lie of the patient. Uh, so many times just watching the patient will tell you which hip is squaring the pelvis. What is squaring the pelvis? So I will jump. Initially you look, then you feel, right? So feel is palpate. So how do you square the pelvis? What do you mean by squaring the pelvis? Both the ASIs on the same. So squaring your pelvis is both the ASIs or anterior superior. Preferably would like to say full form in the exam. Anterior superior iliac point at the same level. And when you have to do the two limb length measurement, you have to do one more additional thing. That not only that you have to square the pelvis, but you have to keep both limbs in identical position, right? If these two requisites are not met, then you cannot do the true limb length and distribution, but you can still measure a apparent limb length. So apparent, you measure it from the CT scanner, the way both the limbs lying close to each other, and till the end of the medial malleus, before the medial malleus. And here, you square the pelvis by keeping the affected limb in appropriate positional deformity. So till the pelvis both are at the same level. So by and large, your 10 degrees is around 2.5 mm of short. Okay. So you can match that. Suppose you have 20 degree of deformity, abduction deformity, it should be around 2 centimeters of apparent length. Okay, unless in that previous case, in this, where there is a abduction deformity, but there is some amount of cartilage loss, so this calculation will go haywire. Yeah. Thomas's test, just a few words about this. I can disclose this secret. This is for other examiners who wouldn't like that, but I wouldn't mind disclosing secrets because there are few FAQs by the examiners, and they expect you to have that. So Thomas's typically it's a classical Thomas's test and modified Thomas's test. Thomas's test, when he described, it was way back in 19th century. It was just to pick up whether there was a flexion contracture of the hip or not. But if you see the reliability or sensitivity and specificity, it is very low. It is between 30% or 60%. So there is a leeway, and only thing you should not miss it. Maybe a few degrees, 2 to 3 degrees of 5 degrees of flexion difference you may miss. But here I am trying to tell you that you have to put your findings in line with your examination science. So you cannot say that there is a flexion. If there is a flexion deformity, there will be some sort of apparent shortening. Okay. So these things, if there is an incoherence, then there is a problem. Classical, it will matter. How much amount you have to flex. Classically, you flex the opposite hip till the lumbar lordosis. You see the lordosis. You can see the gap. You can see it across, and then obliterate it till the lordosis disappears. But then don't check that pelvis is not pelvis. So you have to keep one hand on the pelvis. Ask that person to hold the with the opposite hand, so that you can't have, you are taking the one hand, you are putting it beneath the, so that lordus is obliterated. You are keeping another one on the pelvis to check, because the pelvic tilt will also cause pseudo, if there is an posterior pelvic tilt, it will create a pseudo flexion deformity. So you check that the pelvis is not moving, and then try and extend the affected limb and check it. The modified one is to make them sit, drop the, this is modified, and this will, sometimes what happens is, if you are lying on a straight table, there are associated deformities of the knee. So this will be eliminated, and it tests 4 things: iliopsoas, rectus femoris, TFL, and hamstrings tightness as well. So it improves the sensitivity and specificity additionally. So then when you are describing the range, you describe the range which is active, okay. Describe the, say your flexion is from this much is the amount of deformity as tested by whatever modified Thomas's test or Thomas's test. Further flexion is this. The pain, it is associated with pain throughout, or as a pain is only at the extremes of the range, associated with grating or crepitus, something like that. So that suggests that you are trying to point out to the possibility of arthritis in that particular case, right? And okay, so same thing in adduction, abduction. You can describe the range and describe the deformity there, and there are many lines and various angles. If it is a single joint involvement, then people are fond of asking you what is Kothari's angle. So Kothari's angle is nothing but you draw the two ASIs and then draw horizontal. That's the angle, which is true if you have deformity only one hip, the other hip is normal. Okay. So adduction, abduction deformity, further range in that particular plane, and whether it is associated with spasm or crepitus and pain there during the. Go back to the then rotation. The classical, though we check the rotations by a roll test rapidly in the OPD by keeping the patient in supine and try and roll it, but it has a side effect where it can rotate to the tibia. Okay, so classical ideal way is to make the patient prone and flex the knee 90 degrees and check it, so that you can use that as an arm of the goniometer, and you can actually measure it with the goniometer. Always carry a goniometer in your pocket. As I'm sure this must have been covered. What are the basic instruments that you need to carry? Goniometer, the hammer, the tuning fork, 2-point for 2-point discrimination, all these things. And if you have a child, perhaps a toy. Pediatric orthopedic surgeon will tell you, carry a toy or some chocolate, not to inside your bribe, but he stops crying so that you can examine the patient then. So do that. Two limbs, as I told you, square the pelvis, keeping both the hips in the identical position. Okay. First one side, if you have to adduct one side, then you measuring the other, you cross the hip on the opposite side. This was an inspection, but you will check that and go rapidly. This is another test. See whether it is femoral or Gary-Essay test, whether it is a femoral shortening or tibial shortening. The tibial shortening knee is lower position than the affected side, and femoral shortening knee is more proximal. So that you can examine from the front and from the side. Then all these lines, you have to draw, measure these which they are expected to know. The student is expected to know. You have a Bryant's triangle, so you measure first. Again, here also you have to square the pelvis. Otherwise, it is not comparable. So you do the same, all those things which are required to square the pelvis and keep both the limbs in the identical position, both the limbs. Otherwise, you cannot measure by the Bryant's triangle. They mark anterior superior iliac spine, mark the tip of the trochanter, drop the particular, measure this line. And then you have, if this is not possible, then so if this is not possible, then perhaps the what we can do, if the hip is mobile up to 45 to 60 degrees, then you can measure it by Ellerton's line, not absolute measurement, but you will know whether there is a supratrochanteric shortening or not. So if the tip of the trochanter should be just touching the Ellerton's line, that is normal. If it is going above, then there is a supratrochanteric shaft. Then you have all these shoemaker's line and his lines. These are projected from each side to GT to ASIS, and they should meet in the midline about the umbilicus. If there is a proximal, if there is any problem, then they will meet on the opposite side away from the midline, and they will meet below the umbilicus. If there is a bilateral line, a bilateral problem, again they will meet at or near midline but below the umbilicus, depending upon the amount of deformity. And there are special tests. I will not go into the details. This is not something, this is for hypermobility. You will not get any case of Ehlers-Danlos syndrome, that is very rare. That is for and for our practical point, we don't keep any case of femoroacetabular FAI, femoroacetabular impingement. So this is also not, this is for you to know, and but usually we would have this. So don't forget to examine the sacroiliac joint, especially in the cases of ankylosing spondylitis. So you should know all the tests for including Weber's test, pelvis compression, distraction test, Gessler test, complemental test, active SLR. These are the tests for the sacroiliac joint. So do test them, and you cannot lose them. And after having examined and you are making a diagnosis of the spine, examination is extremely important. Chest expansion at the level of the nipple is important, less than 2.5 centimeters is important. Loss of range, of course, I'm sure in the spine examination they must have covered this. Typically, the hand span is the place where you lose range in all movements, so flexion, lateral, forward flexion, extension, and lateral flexion. Whereas this, if there is a disc prolapse, you have selective restriction. You have, say, axillary disc, then you will have this lateral flexion on the opposite side will be restricted, and forward flexion will be restricted. Whereas you have shoulder disc, the opposite side. On the same side, it would be fixed. So you do that, then I will skip through this. These are special tests. So we do not see now any more polio. Polio, we used to have this IT band tightness, and the most common question was enumerate the deformities caused by IT band tightness. So you have to examine the overt test. So now we do not get it. So unless it is relevant, we need not mention it. But the Trendelenburg test and the Trendelenburg gate is important. For example, it is important when you have, say, for Coxa vara, but this is causing late onset deformity with the Coxa vara or non-union of the IT or TC, where there is a overheading or congenital dislocation of the disc. Okay, so in these cases, Trendelenburg test is important, and we know how to do that. You have modified test where you ask him to hold his hand for some time, not to take weight on that, hold his hand, and he should take at least 30 seconds, stand on that hip, and if the affected hip, if is there is either a problem with the fulcrum or the lever arm or abductor power, then the pelvis will droop on the opposite side, right? So that's a modified Trendelenburg where he stands for at least 30 seconds. So, and I classically stand behind, not in front, see the pelvis drooping. And if you have Trendelenburg test present, then it is necessary that means he is able to stand on that limb for some time. And don't say that now it is a antalgic gait. You are one side you are saying Trendelenburg test present, and that gait you are saying is antalgic. Don't do that. He is able to stand on that limb for at least 30 seconds. So the gait would also be Trendelenburg gait. So this is what I am, use your some sort of a common sense here. Your findings should be coherent. When you are saying Trendelenburg test present, don't say that gait is antalgic gait or short limb gait. That cannot happen. So put these things together. Again, these are tests are, you can see the reliability, but then our pattern of examination is such that we have to rely on that. So as long as it is totally revamped, we need to continue doing this test. And then telescopic test. Again, if you have, you may have neglected posterior dislocation of the hip after a fracture, posterior lip accidental fracture and dislocated hip, or you may have neglected congenital dislocation of it, or you can have IP fracture, which is or basis alarming fracture for that matter, non-Indian. You can have that telescopic test present. So you can, these are the special tests. So there I end with a very short. I think as you present, I think we will get more and more idea. Perhaps we can suggest you more. We have people or your professors, and we. So I think we can begin with the. Is it okay? Is it pattern? You want to? Okay. Okay. So we can finish the.